And meta-analysis clearly told it has got the ability to differentiate between early gastric cancers and locally advanced gastric cancer. It is a schematic picture where it shows an ulcerative growth, where you could see in the endoscopic ultrasound image a transmural involvement in all the layers. And coming to CT scan, it's a first line investigation as per the guidelines. It denotes in mainly in T4B, where it outscores over endoscopic ultrasound. And the limitations are, it cannot detect early gastric cancers. It has a limitation in detecting early peritoneal nodules, microscopic serosal invasion, and it has got a limited accuracy in nodal staging without biopsy. That's why nodal staging should always be complemented with endoscopic ultrasound. The sensitivity in detecting serosal involvement is about 80 to 90%, and whenever you see local advanced cancers, you should always remember that a peritoneal metastasis should be ruled out. Coming to meta-analysis between endoscopic ultrasound and CT scan, endoscopic ultrasound is always helpful as an adjuvant tool in early gastric cancers in T1 staging and end staging, especially with FNAC. Coming to PET-CT, it's nowadays a modern routine. Whenever a patient walks into our clinic, just we'll write PET-CT to rule out anything. You must remember, especially in gastric cancers, which is based on FDG uptake things, here it is indicated only in nodal positivity and any lesions above T3. Whereas it is not useful in mucinous tumors because your FDG uptake is less. And it is not routinely recommended, as I told you, and it will not detect peritoneal disease. Coming to types of FDG, the standard of care as per NCN till today is FDG-PET. The promising thing which you are noticing is FAPI-PET. Why? Because it has got uptake irrespective of the histology, which is useful even in mucinous. And this is a picture you can see where you could see the difference. The uptake in a mucinous tumor is seen on FAPI-PET. Regarding biomarker evaluation, I would like to tell, these are the mandatory biomarkers usually we tend to neglect. Whenever you come across a locally advanced gastric cancers, try to ask for a histology regarding these markers, because it will always helpful regarding assessing trastuzumab for HER2 and this PD-L1 receptors for making immunotherapy decisions. And it can be taken at the time of diagnosis and primarily preferred from primary lesion. And as I told you, the staging laparoscopy and cytology plays an important role. It is especially useful in T3, T4 lesion and nodal positivity. And always you should have a curative intent surgery, you need to go ahead with staging laparoscopy. Coming to peritoneal cytology, even though you don't see macroscopic disease, if at all cytology is positive, it comes under metastasis. So as previous speakers were telling that, whenever you see that lesion is resectable, but still you find cytology is positive, you should always give time for neoadjuvant and then reassess. This is why it is important, because it detects occult peritoneal metastasis and it will alter our management. At least surgery is futile in 30% of the patients where we could avoid unnecessary laparotomies. So this is the flowchart what I have been discussing. And finally, to take home, I would tell 2 points to be understood. One is staging laparoscopy should be the norm in locally advanced gastric cancer, where it is going to alter our patients, avoiding unnecessary lap. The other one is the PET-CT is not a routine investigation for gastric cancer, and it's a multimodality treatment where in locally advanced gastric cancer, you should involve all specialties to have better outcomes. Thank you, everyone.